So I'd like to say hello and welcome to everyone on the call right now on this webinar. Thank you for joining us. This is the fourth Learn and Lunch webinar series on aging. This series was designed to provide knowledge and skills to providers on key health topics for older adults. Today's presentation is on gambling among older adults, which was requested as a particular area of interest in this series by one of our participants. This webinar will be presented as a lecture by Dr. Foster, who I will introduce momentarily. Please hold your questions until the end of the presentation, at which point we have some time reserved for Q&A. I'd also like to ask everyone to please mute their phones. This session is being recorded. The session will be archived at our website, jerryscholars.org, for anyone who was unable to attend today. And I'll provide that website it's in one of the final slides today, so you'll see that later. I'd like to also just introduce myself to you. My name is Jake Deering. I'm the program manager for the Consortium of New York Geriatric Education Centers. So I'm managing this webinar today, and again, I'd like to welcome you all and thank you for joining us. Next, I would like to turn this over, or I'd like to introduce my colleague, Dr. Andrea Sherman, who's a curriculum consultant to this program, and she will welcome you and provide some additional background on CNY GEC. Dr. Sherman?
Thanks, Jake, and we're delighted to see so many of you participating with us today. And this series is sponsored by the Consortium of New York Geriatric Education Centers, which provides education and training in geriatrics throughout New York State. And as Jake mentioned, this is the fourth in the series. We anticipate being able to work together with you to develop this series again next year, and hopefully at the end of the call, there'll be some time so that we can perhaps form a group to continue thinking about what topics would be best. So we meet the training needs of healthcare professionals, paraprofessionals, volunteers throughout New York State. And Dick, if you could move it to the next slide, then of specific interest on this is that this program outreaches to the New York tribes, and we hope that we have participation from Oneida, Seneca, St. Regis, and several of the other New York tribes. And I don't know if anyone wants to give a shout out. And we also have participants, I think, from the Northeast Quarter. And Regina Verdi, are you with us today? Regina is the new Indian Health Services New York State Department for Health representative. I'm not sure if she's on the call or not, but if she is, welcome. And with that, I think I'll turn it back over to Jake, and we can take some time at the end of the call. And if you have questions along the way, you'll see there's a little chat box there that you can write your questions in on or comments. Thank you.
Thank you, Dr. Sherman. So next, I would like to introduce our speaker for today, who's going to lead this presentation. Dr. Elizabeth Foster is a graduate of the San Francisco State University with a bachelor's in nursing in 1988. She graduated medical school from Oregon Health Science University. Later, she completed her residency in psychiatry and fellowship in child and adolescent psychiatry at Dartmouth Hitchcock Medical Center. Dr. Foster worked at the IHS in Arizona for 5 years. She moved to Albuquerque, New Mexico to complete her addiction fellowship, and now works as an attending psychiatrist and as the medical director of the Adolescent Substance Abuse Program. And she also works with adults through that work. Dr. Foster, welcome. Thank you so much for joining us from your home office today, and please, you can begin now. Thank you.
Thank you. I just wanted to say a special appreciation to Jake, because he was actually getting my final version of this presentation at like 6:30 this morning. I do appreciate Dr. Sherman and both of you inviting me to this to complete this telecast. Jake, were you going to give me control again?
I just did that. Let me try one more time. How's that now?
Yes. Okay, let's try it. No, it's not working. Go ahead and go to the next slide while we try and send it to me again because a little conversation came up. Okay, it says now I do.
Okay, there you go.
Okay, perfect.
Thanks.
So as Jake said, after I spent 10 years actually doing sort of the family practice of psychiatry in Chinle, Arizona for the Navajo tribe for 5 years, and that's what drew me into the interest of further doing an addiction fellowship. At the end of this presentation, I really hope you guys to understand the impact of gambling on older adults, to recognize significant changes in DSM-5 that's very positive for gambling disorder in the future research, and relate the differences of recreational gambling versus gambling disorder in older clients, because recreational gambling can be an important part of social activities for older clients. Discuss the unique aspects of Native American gambling, and this is actually very limited, but I'll share with you what I discovered in my research, and your older patients be able to identify some positive aspects of gambling, but also notice the risk factors for developing a gambling disorder. It's helpful to have a vocabulary that you can use with patients to discuss their gambling habits and to further assess, identify, and treat gambling disorder. Overview. This is sort of very connected into the objectives. It's important for us to understand the changes that have occurred in adult population due to the fact that there's legalization of gambling, and there are multiple increased gambling venues for older adults. Consider the impact for you as clinicians on the limited availability of research for Native American populations, and to develop an assessment and treatment plan despite the paucity of research. Backgrounds, seniors, and that's a variable level, very varied age groups. Some define it as over 55, others over 60, but that age group is the fastest growing groups of gamblers. It's the most frequently identified social activity among adults over 65, with casinos and bingo surpassing movies, lunch, shopping, and golf as preferred social activities. There are many opportunities to gamble, and casinos offer free bus trips to bring older adults from senior centers and retirement homes. There's charities that offer bingo nights and raffles as older adults for social events. So it's very common access and time. This is one of the pictures. If you put in senior gambling or older gambling, you get an array of pictures, but the prevalence rate overall is reported as being 0.3 to 3% per lifetime of gambling in senior citizens, with 1% being reported most consistently. Also, it's more agreeable that men to women, about 2 to 1. However, the research is very limited, and so accepting the prevalence about 1% of gambling disorder. Oh, sorry. Let me go back one. Boy, this skipped quite a few slides, excuse me. So demographics, the commonalities among those that sought treatment. One of the most interesting studies I reviewed is that of those who went into treatment, they spent more than 15 hours per week gambling. They lost about 64% of their yearly income, and they began gambling later in life. Only 13% have reported an onset before 55. So in future, when we talk about assessment, discussing with your clients how many hours a week they're actually gambling or in the casino can be very helpful. Specific populations with higher rates of gambling are women, patrons of casino bus trips, residents of senior citizens, those that attend bingo halls, ethnic minorities, veterans, and individuals with disability. Those who patronize casinos tend to be widowed, less educated, poor, without transportation, and to report more mental health problems and less social support than non-casino patrons. These patients, these people are not all go on to develop a gambling disorder. This is just the characteristics of people who gamble. Gambling disorder is formally pathological gambling, and there was also problem gambling, and now DSM-4/5 has moved it into just one disorder, gambling disorder, and later we'll review the criteria, which are mild, moderate, and severe. The most important change with DSM-5 is that we're now part of a new section, substance-related and addictive disorders, and gambling is considered, non-substance-related addictive disorder. It's part of a new section on behavioral addiction, and based on the research, it's the only disorder that has made it into this section, but there are other future research for, like, sexual addiction is a good example that they feel will fit into this category of behavioral addiction. This is based on the research that shows that gambling activates the same dopamine reward system that it does of different drugs of abuse. Now, gambling disorder criteria has changed in the fact that it used to include a legal component of, in order to meet this criteria, you had to have had some involvement in forging checks, taking money, lying, thieving, and it is no longer part of this criteria. What's important is there is a persistent and recurrent problematic gambling behavior, and if you can look at the criteria instead of just a list and key it into specific criteria and words, this will help you in asking questions about gambling later when you're doing your assessment. This is a person that needs to gamble with increasing amounts. They become irritable and restless when they cut down. They've tried to cut down and have not been able to successfully do this. One of the elder clients that we see here, who's 72, there was a notable change in her affect at work, and that was because she was trying to not gamble for a specific period of time, and she really noticed her mood improved when she actually went out and gambled one night. People who have a gambling disorder are preoccupied with it, and they spend a great deal of time focused and thinking about gambling. They can't get it out of their mind. They gamble when feeling distressed. After losing money, they often return another day to get even or chasing one's losses, which is very common. People who chase after their wins, what will happen is they will lose $100, and then what they'll do is they'll bet $200 at the next event trying to get that $100 back. They lie to conceal the extent of involvement in gambling, and this is very important for seniors because they will go out of their way to avoid telling their family. They have jeopardized or lost a significant relation, job, or education. And for seniors or older patients, they actually lose a significant amount of their retirement or their Social Security. They rely on others to provide money to relieve desperate financial situation caused by gambling, and that's if they actually discussed it with their family. The gambling behavior is not better explained by a manic episode. And there are lots of other exclusion criteria in DSM-5, but this is the only exclusion criteria for gambling disorder. There is a unique difference about gambling disorder and DSM-5 because they do distinguish as a specifier whether or not it's episodic versus persistent. And this is difficult in terms of addiction disorder because if you look at alcohol use disorder, you would say they are in early sustained remission after 3 months or full sustained remission after 12 months, and we still use those words in gambling disorder in that criteria, which is opposite than what episodic means, because gambling disorder, there can be periods of time, whether or not it's a few weeks or a few months, where people don't gamble versus people who are consistently gambling. And I think that this is going to have to be clarified in future editions of DSM-5. So associated features, according to DSM-5, are the chasing, trying to undo the loss by placing larger bets or taking greater risks, bailout behaviors, but which we both discussed. But distortion of thinking is a significant part of that. There's denial, there's superstitions. One client felt that if I wear these socks, if I engage it, if I take $33, I only bet on 13. Those types of superstitions are very prominent in gambling. And there's, they also have a sense of power and control. And when you look at other disorders, you talk about this loss of power and control over the substance, and that's not always seen in gambling disorder. Let me see. Jake, do you want to see if you can move it forward? So factors that may increase vulnerability to developing a gambling disorder, you want to assess for dementia or other cognitive impairments. And if you have patients with a longstanding history of alcohol use and you see an increase in their gambling or increase in impulsivity, you want to look at what the impact of the alcohol has been on their cognitive abilities. Lack of understanding of odds and probabilities. There is a large part of the population that don't understand that the odds are in favor of the casinos. And so what they'll do is get on the bus, go down, they'll take their $10 and feel like if they just gamble a little bit more, they'll get their money back. It's not the same thing as chasing your losses. It's more like, okay, I'm going to eventually win and get my money back. There are people that believe gambling is safe and benign and even healthy. Now, that's hard for me to believe because you walk into a casino and you can't breathe because there's smoke everywhere. But it is a part of some older adults' activities, and it is different than pathological and compulsive activity. And seniors will say, well, I'm not like the people on TV that do the, blackjack games or poker games, and they see themselves as being separate from, but still can develop a gambling disorder. Older adults have more time and income, and the assumption is, the assumption is all older adults in the research have this disposable time and income, but as we know, many people do not have disposable incomes and don't have the ability to sustain losses. There's two medications that you need to look at can increase impulsivity in Parkinson's disease. The medicines, the dopa agonists that they use can make them at risk for gambling disorder. And Abilify, which is just an atypical antipsychotic that's used, aripiprazole is the other name. I'm sorry, I should have put that. The generic name is often used for many different situations: mood, bipolar, psychosis, schizophrenia, and it can also increase your risk for gambling. There's lots of changes in elderly that make them vulnerable: retirement, death of a spouse, more time and resources, loneliness, lack of social opportunity. And finally, casinos target their marketing strategies to attract more senior patrons by free bus rides, food, and special events. And just like everything else, some people, according to the statistics, 99% of the population can benefit for that. It's just the 1% that ends up going on to developing a gambling disorder. Okay, Jake, you can move it forward. It stopped working. So as I've kind of alluded to, it's not all negative. There are older adults that enjoy gambling but do not develop a gambling disorder. And some of the people that go on to not develop a gambling disorder have fewer resources, greater support and mobility, higher self-reported health, and lower rates of depression. Okay, next. Characteristics of recreational gamblers. They gamble less than 5 times a year. They have lower rates of substance use, nicotine 17%. Okay, I'll take that. Thanks, Jake. Alcohol use disorder, 30%. Psychiatric mood disorders are around 13%, anxiety disorders 15%, and personality disorders around 11%. These are less than patients who have gambling disorder. Motivation to gambling for fun and socializing is the greatest, 36%, something to do, 24%, and as you can see, shows and entertainment, 10%, food, 24%. So only 6% of those of recreational gamblers gamble to win and to actually play for that opportunity. You know, Jake, I'm sorry, but I don't know why the controls aren't working.
It's okay. From now on, just go ahead and say next, and I'll move it forward.
Okay, thanks. A study of those that sought treatment for gambling, that I had mentioned that study earlier, 50% had suicidal ideation and 17% had a suicide attempt. And although we know we should screen all patients for suicidal ideation and suicide attempt, it's important to understand that those statistics. In terms of just gambling disorder and comorbidities, personality disorders, antisocial personality was high at 42%, alcohol abuse or dependence 33%, and adjustment disorder 17%. Next. Another study found that substance use at higher rates with the nicotine dependence 43%, alcohol abuse 53%, and non-alcohol drug disorders 5%. And nicotine use disorder, nicotine dependence, is the highest and has the greatest risk factors for loss of life due to tobacco use. Mental health disorders, mood, depression, and bipolar. And these statistics are important. Anxiety disorders and personality disorders, because when you move into pharmacological treatment for gambling disorder, targeting the mood and anxiety is an important step to help improve outcomes and decrease gambling. Poor health outcomes are obesity and worse overall physical health. Next. The impact on older gamblers is that they lack the ability to recover from hitting bottom, which is a term that's used a lot in gambling and other substance-related disorders. There's increased rates of substance use and depression. There's a great deal of guilt and shame, which is unique in the elderly because they don't want to share it with their families. There's a significant loss of income and assets, which can result in the inability to pay copays for medication and health care, serious social and psychological and financial costs, and finally, the isolation from the family, as I've talked about before. Seniors will go to extravagant means to hide it from their family and friends. Next. This is a case that I found in the nursing journal that reported in the one of the very last slides. This is a patient that came into a clinic in a senior housing building, and the nurse practitioner taking care of her noticed that she was there today and was sort of, dreading her coming in to see her, Mrs. Spade, because although she'd been a long-standing client, she was having difficulty in helping Mrs. Spade with her health problems. I don't know if you're not unique. There are some patients that we really struggle with and taking care of and finding that right balance to help them move forward. Next. So her compliance with appointments were good, but she continued to be stressed, tired, tearful. She was on both an antidepressant and an antihypertensive treatment. Her depression and blood pressure never improved, and Meg was not optimistic that today would be any different despite new medications that had been tried 2 weeks ago. Meg was working with a student, and they were together going to see this patient. Next. So as expected, she arrived, and the student took her blood pressure, and it was 182/98, and Meg entered the room and found the patient talking with the student, and afterwards, after completing her physical exam and changing her medications, there was a discussion with Mrs. Spade and the student. Next. After she left, Meg commented that she and the student got along, and they had shared a discussion, and it turns out that the student actually knew the patient from a local casino and was aware that she had lost a great deal of money at her table in the past. And so for the first time, the nurse practitioner could really see the missing link and what she was missing with patients. And I think that this is a story that happens over and over. We will say to practitioners here that if you have untreated blood pressure over 2 medicines that you've tried, if someone is stressed and there's been 2 trials of different antidepressants, look for alcohol or other substance use. The other lesson in this story is the fact that oftentimes our patients, whether they're older clients or adolescents, no matter what age, after they've developed a relationship with you, it's very difficult for them to reveal what they actually are engaging in, and that they're doing something and they want to tell you, but they can't tell you because they don't want to tell anyone. And so learning how to ask the questions in a conversational style that will give them the opportunity to tell you things that are difficult is important, particularly in gambling. Next. So the assessment for gambling disorder, there's a screening tool. There's several, but the one that we're going to discuss is a 2-question tool that you can use very easily. It's called the Lie/Bet screening tool, and I have a slide to discuss the questions. I also know that when I worked at IHS, it seemed like we had, like, when you screen for gambling, depression, anxiety, suicidal ideation, that sometimes visits can become very overwhelming. And so being able to look for and use this questionnaire at different times, if something comes up that they say they gamble, and then knowing these 2 questions in your mind can later help you identify a behavioral problem. If someone says, yes, I spent all weekend in the casino, then you can go and ask these 2 follow-up questions, and it can help you identify gambling disorder that may have not shown up in previous questions. Assess for suicidal ideation. I left this like a parentheses around this example and actually was going to leave it blank, and then Jake said, well, it is blank. But whatever tool you use is available in your clinical area for suicidal ideation or suicidal thoughts is important, because we all know the statistics that a large percentage of patients that have a successful suicide attempt or unsuccessful suicide attempt have seen a practitioner previously to that event. So understanding how you ask questions about suicide is important, and what the cultural meanings of those are. You want to assess for underlying medical problems, dementia, Parkinson's disease, hypertension. You want to look, like I said, at medications associated with excessive gambling, aripiprazole, which was Abilify, and dopamine agonists, which are ropinirole and pramipexole, I don't say that very well, and levodopa. Next. So the lie bet questionnaire is very simple. Have you ever had to lie to people important to you about how much you gambled? And the follow-up question is, have you ever felt a need to bet more money? If you get an answer to that, then that leads you into the ability to answer more questions. If at the end of those 2 questions they say no, then you can pick a couple of follow-up questions that you've developed. Particularly, do you get anxious or feel irritable prior to being able to go to the casino? Anything that you're comfortable with that can lead you to further answer questions, get them to answer questions in a different manner. Next. When you're assessing gambling disorder, you want to make sure you look at comorbid psychiatric problems, depression, substance use, PTSD. You want to look at the past history of gambling disorder, and you want to look at psychosocial changes, particularly in family relationships and isolation from peers. And you want to particularly look at the DSM-4 criteria, like we said, lies, cravings, but you want to ask about gambling patterns and losses. How often do you go? How much do you gamble? Next. So before we move on to this, Jake, there were slides on epidemiology for Native Americans, and those slides are not in this presentation. Do you remember that? They were at the beginning.
I do remember them. I guess I'm not sure where they must have gotten lost. I'm sorry about that if they're not here.
So are you sure we skipped over?
They were on this one.
They're on mine, and I can let me pull up mine because I think that they're important. Go back to the very beginning of the presentation, because there was a slide, and I saw it. Keep going, the very beginning. So we missed that. There it is. Now go up a couple more slides. Okay, starting right there. So this slide, this is taken out of context, but I said if gambling is the Cinderella of addiction medicine, seniors, elderly, older adults are allowed to watch from the sidelines, and Native Americans were never invited to the ball. And this is directly related to the fact that there's limited research on gambling. I just returned for the American Society of Addiction Medicine conference in Austin, and there wasn't one presentation at that meeting on gambling. I reviewed 5 different addiction medicine texts, and 2 of them did not even mention gambling, did not have a separate section on gambling. And so overall gambling, as this quote describes, is that it's been consigned to a kind of peripheral position in the addiction field in modern times. And it's because of this and because of the growing actually older people gambling, it's important for us to understand. Then when you look at the gambling literature, it doesn't really clearly define age. And so when they say seniors, elderly, older adults, then what they're saying is that it can be anywhere from 55 on up. And so the research is just not available. Then you can go to the next slide. Then when you're looking at the research, it's limited and it's growing, but there is no research that involves Native Americans to barely any degree. There's some isolated gambling articles that if you pull up a literature search in PubMed, you may get, if you put in Native American in gambling, you can get within the last 5 years around 30 articles. But when they're doing research on older clients that come in, they don't include a section or any evaluation of Native Americans. They may not be included in the study, but there's no reference at all to Native American. Okay, you can go to the next slide. The past year prevalence of gambling among Native Americans is similar to the rate for non-Native Americans. So if you look at all people in the U.S. that gamble, 80% have gambled within the last year, or 77% of Native Americans. So it's the prevalence is very close. However, Native Americans have over twice the rate of problem gambling, and this one study was completed before the DSM-5, obviously. The most challenging study to read and something to think about is in a Canadian study, 80% of the Aboriginal race in the past year experienced discrimination, and past year racial discrimination was a risk factor for 12 months problem gambling, and gambling offers an escape. And so when you consider historical trauma, when you consider racism, you're increasing the risk for gambling. Next. Further studies showed that American Indian veterans had a 10% lifetime prevalence of pathological gambling, which is higher than other research for non-Native Americans. Comorbid conditions associated with pathological gambling, substance, mood, and antisocial personality exist, but are at higher rates. Ready access to casino gambling may encourage, support, or contribute to high rates of pathological gambling for Native Americans in both men and women. And when you think about it, access on reservations has increased. When I worked in Chinle, Arizona, there were no gambling. The Navajo Nation did not have gambling, and now they actually have a casino in Gallup, New Mexico. Social achievement and disposable income function as a prerequisite for recreational gambling in Native Americans. And although externalizing or risk-taking disorders also serve as an independent contributors to at least some gambling. And I think that then we're caught up. Oh no, the next. So I guess we're not. So the factors influencing the risk for problematic gambling are economic status, unemployment, increased alcohol use, depression, historical trauma, and adult American Indian males and females appear to possess equal risk of problematic gambling, which is not true in the other literature that I looked at. Next. The gambling industry has grown from $17.4 billion to $860 billion revenue. 125 million people in the U.S. are gamblers. 7.5 million of the American adults have a problem with pathological gambling. Individuals over the age of 65 represent about 7.2% of this group. And as we reviewed before, gambling ranked the highest among social activities. Next. And that's where we actually picked up. So you can go to treatment. There are few outcome studies that have been conducted for gambling in general, let alone specifically for older clients. There is no FDA-approved pharmacotherapy with an indication for gambling disorder. And I think that in some ways, as we've grown in the last years, relying on evidence-based medicine, I think evidence-based medicine has kind of moved us away from the multidisciplinary approaches to problems in medicine that we've had in the past. And so gambling disorder, although it's missing this data, gives us an opportunity to work more together as a team. Next. Pharmacotherapy, and I'm not going to read this entire slide, but the two most important parts are that the most effective when directed towards the patient's comorbidity in terms of pharmacotherapy and medicines is to treat the comorbidity, bipolar, OCD, ADHD, and never forget the suicidal ideation to be considered. And there are double-blind, placebo-controlled studies, and of all of these medications listed here, naltrexone, which has 2 double-blind, placebo-controlled studies, suggests some significant clinical efficacy over placebo, but they're small and further studies will be needed. I'm sure will be forthcoming because of the financial rewards of having naltrexone as an FDA indicator for gambling disorder. Next. CBT is an effective treatment for gambling if it focuses on challenging and correcting the patient's errors of thinking, but like I said previously, the full efficacy hasn't been established. Trying to help problem gamblers and gambling disorder clients identify the stressors and the reasons for gambling and confronting the defenses and cessation of chasing behaviors can be effective in reducing gambling, the amount of gambling in patients. Next. Enlisting family members to assist in encouraging the pathological gambler is very key, but it can also be very challenging because if you go back for older gamblers, telling their family can be one of the most difficult things they do. Treating the comorbid conditions and providing the gambler and the family members with support resources can be helpful. And this is the Council on Problem Gambling, and you can click on that website, and that website will lead you to more information, and it will also connect you with local state affiliations if you would like to see what is available in New York. Next. Psychosocial treatments. You can ban yourself from a casino. And this can be very effective because if it's one of the first interventions that you do when you start working with a client, but a lot of older clients prefer lottery tickets, so wear lottery tickets everywhere, that you can also have internet gambling. So this in and of itself is not always as effective, depending on what your client's preference for gambling is. Gamblers Anonymous, I have a slide on this in a little bit, involve family for support and counseling. There are state-funded treatment providers in multiple states. It's part of the part of the gambling funds goes to provide a list of treatment providers. Next. Gamblers Anonymous is modeled after Alcoholics Anonymous. Gamblers are in a 12-step program, and at the same time, the effectiveness has not been demonstrated like it is for other substances. And this is remember when we talked about episodic versus persistent, this last statement, some researchers have discovered that complete abstinence from gambling may not be necessary for successful treatment. However, I would just like to put that into the context of we don't have enough research, and that's a bold statement to make. Next. The psychosocial approaches, I pulled this from the nursing literature, and I think it's very helpful. Actually, it's more holistic. Look at social and community resources, spiritual and cultural as well, provide education on the hazards of gambling, and go back to one of the earlier slides where the research shows that there isn't always availability of the knowledge about the dangers of gambling. Assess patients' previous methods of dealing with life problems and try and identify what has been helpful for them in the past. Identify support systems, encourage family support, provide counseling, and participate with the patient throughout relapses. Next. These are the resources. Those are the two articles that I mentioned. And of the two, I really like the assessment and management of pathological and problem gambling among older adults. Next. So summary, gambling disorder is now considered under the substance use disorder and non-substance related disorders as a behavioral addiction. With the growth of gambling, older adults are at increased risk for developing a gambling disorder and should be screened for this. The live bet is an easy to question screening. The paucity of research on Native Americans needs further advocacy to increase the availability of research. And assessment and treatment can be implemented with success using a multidisciplinary approach.
Right. Thank you, Dr. Foster, for that terrific presentation. This is such an important topic to consider as we care for older adults. So I really appreciate your presentation today. And at this time, I'm going to unmute everyone's lines and we have some time built in here for folks to have questions for Dr. Foster if there are any questions from anyone on the call.
Well, Jake, I'd like to start it off. This is Andrea. And one question that I have, and thank you for your excellent presentation, Dr. Foster. It was really good, and I learned a lot on a topic that I don't know a lot about. But my first question is kind of a simple one. How would you even be able to gain some kind of entree to begin the conversation with someone about the fact that you perhaps have noticed that they seem to have a gambling challenge? How would you begin a conversation with someone about that in terms of talking about it?
Well, I think it's like any other difficult topic to discuss. I think the reason why we may be uncomfortable as providers is that we don't know a lot about gambling. So hopefully this is the beginning to make us more aware, because I certainly wasn't aware of the gambling impact prior to doing this presentation. But I think that if you ask patients first how much time that they spend socially and what they do, and then ask them, okay, of this time, how much are you gambling? That's one way. So my friend Margarita, well, how much time do you spend at the casino? Because as soon as you start doing any presentation or learning everything, everybody around you becomes a gambler. And I happen to know my friend gambles. Well, she spends, Thursday afternoon at the casino. She sets aside a certain amount of money. So then the next question is, well, how much money a week do you think you spend? Well, that gets pretty dicey because that's a touchy subject. And so going back to, well, how much time do you not spend with your family? So if you build it up in terms of social activity, how much time with your family, or your family upset with you that they don't see you, you can ask all of those indirect questions before you actually get to gambling. That's the indirect approach. And I think in this case, based on what I've learned about older adults and their shame and guilt about gambling, might get you further than the direct approach.
Thank you. That's very helpful.
Does anyone else on the call have a question for Dr. Foster?
Can I ask some questions?
Sure, please.
I would just like to know of any of the participants, since you were the people that asked for more information about gambling, how much have you seen gambling impact your community over the last 10 years?
That's a great question. For anyone who's on the call that for some reason might not be able to connect with us via phone, you can also reply to that question via the chat box if that's easier or more, if that's the only possible way for you to communicate with us. So the question, Dr. Foster, is how folks on the call have seen gambling impact the patients that they see in their practice.
Or in their community, family, friends.
It's awfully quiet out there. I see lots of names on there, so it'd be great to have some participation from Rachel or Robert or George or any of the other
everyone.
folks that are on the call.
Hi, I actually have a comment. Can you hear me?
Yes.
Great. This is Annette Thomas. Thank you so much for a wonderful and insightful talk this afternoon. I actually serve as the manager for a rural health training and education initiative. It's a joint collaboration between the Bronx VA and the VA Hudson Valley healthcare system. So our program enables trainees to have the opportunity to work with veterans living in rural and highly rural communities throughout the Hudson Valley in New York State. And the topic of gambling and addictions is one that I'm definitely seeing as being more prevalent among individuals living in these remote areas. So I'm really interested in learning more about resources that are available, any specialists that are available to help address and assist this really kind of growing problem, because like I said, I am discovering that it is quite a big issue and challenge in these rural and highly rural communities.
Well, that's kind of interesting that you say that, because when Dr. Force was stated that they were looking for someone to give a presentation on gambling, it was sort of like, well, do you know anybody that is a specialist in gambling? And we thought, well, maybe there's a psychologist in this area that's a gambler. And then it came back to me because I had just, edited a series on internet gambling and video gambling, and it's growing. And so my answer to you is they're very few and far between. There is one book on gambling disorder, and actually I'll send a couple of recommendations regarding this book and the speaker in Iowa that is sort of focused on gambling. And I can do some more research on specific people and send it to Jake so that he can put it on the site or send it out to everybody.
That would be so helpful. Thank you so much.
Great. Yes, I'd be happy to share that. Thank you.
Can you hear me?
Yeah, we can hear you.
Okay.
Go ahead.
Okay, I'm not used to this particular technology. So thank you. That was a very interesting presentation. And you might have covered it, but I didn't hear it if you did. Isn't there a conflict a little bit between sponsorship of gambling establishments by organizations such as tribes as money-making enterprises and therefore enabling members of the community to gamble?
Oh, yes. I mean, I could have done a whole presentation on this, and there's actually every year there is a report from the tribal gaming industry describing the current situation of gaming and the impact of finances on the tribe and the various tribes. And so I purposely didn't enter that conversation because it is, first of all, I'm not Native American, and second of all, I think it's still such a hot potato politically that often it overwhelms the getting to the point of diagnosing someone with gambling disorder and treating somebody with gambling disorder. And so that's why I steered more towards gambling disorder, because in that debate, gambling disorder gets lost because they'll say, well, only 1% of people have a gambling disorder or pathological gambling. And so there were kind of two reasons why I focused just on the gambling disorder, because we have to be able to recognize and help diagnose and treat our patients.
Right. It's just something that has interested me, and I've observed I've just observed. So thank you for at least addressing it.
Yes, and go to the internet and put in Tribal Gambling Pact 2015, and you'll pull up that latest report.
Okay, thank you very much.
You're welcome.
Okay. Thank you, everyone who had comments and questions. We are approaching the top of the hour, and so we wanted to be able to have any opportunity for anyone on the call to also provide feedback on this webinar series in general. This is the fourth webinar that we've held since December with this group, and we wanted to know if you had any feedback for us, or if you have any ideas for future topics, or potentially new format for the way we can deliver this, or any other comments you might have about this whole series. So if anyone would like to share, this would be a great opportunity to do so. Okay. You can also, please feel free to email me directly with any comments or ideas that you might have, and feel free to also ask any colleagues who've been on these webinars who are not on today, and you could also share through email with those folks. Thank you. Okay.
Thank you very much, Mr. Nearing and Dr. Sherman. It was great to participate in this. Thank you very much.
Thank you. We're delighted to have had you.
Thank you, Dr. Foster. It was an excellent presentation. We really enjoyed it, and I also learned a lot because, as Dr. Sherman said, I do not know very much about this topic, and so it was a great learning experience for me. Thank you.
Thank you, Dr.
You're welcome, and thanks again, Jake.
Oh, good. So thank you, everyone, for joining us today, and have a great day. We will hopefully see you in the future, and please be in contact with ideas for future presentations. Thank you so much.